which I thought pretty good. But it was not. And there were houses.
Who are watching the Health and Human Services Committee online, want to welcome you this afternoon, as well as guests that are in the office. I've been working today. All right, let me start from my right, since everybody's on my right, but with the committee members, starting with Commissioner Powell. Please introduce yourself and speak into the mic. I understand that we've had some audio issues earlier with the public hearing us. Thank you.
Can you hear me? This is Mecklenburg County Commissioner Elaine Powell. I represent District 1, which is all of North Mecklenburg, Huntersville, Davidson, Cornelius, North Charlotte, and the ETJ.
Good afternoon. I'm Laura Meyer, and I represent District 5.
My name's Arthur Griffin, and I'm a county commissioner at large, and I have the honor of chairing the Public Health and Human Services Committee. We have a colleague of ours who's visiting. She seems to be a regular visitor. We have to get her on this committee somehow or another. I'd like for our colleague to introduce herself, please.
Thank you, Mr. Chairman. My name is Susan Rodriguez McDowell, and I'm elected by the people of District 6.
Thank you so much. Let me go to our deputy county manager and start the introductions from our senior staff. And please speak into the mic, the others, I know.
Yes, sir. Good afternoon, Anthony Trotman, Deputy County Manager.
Good afternoon, Kim Henderson, Director, Department of Child, Family, and Adult Services.
Good afternoon. My name is Ronnie Devine. I'm the Deputy Director for Community Support Services.
Good afternoon, Raynard Washington, Public Health Director.
Good afternoon, Taya Cruz, Assistant Deputy County Manager.
Afternoon, Robert Nesbitt, Chief of Staff for the Health and Human Services Agency.
Good afternoon, I'm Fonda Clifton, Division Director for Child Support Services.
And let's start over here. If you can just share the mic so that they can introduce themselves.
Thank you. Ben Chambers, Business Manager with the Public Health Department.
Good afternoon, Dr. Shaquetta Johnson. I'm the Assistant Health Director for Preventive Health for the Mecklenburg County Health Department.
And to my left.
Yeah, good afternoon. Tim Gibbons with the Department of Child, Family, and Adult Services, Program Director, Early Childhood Initiatives.
Hello, everyone. I'm Nicole Stanfield. I'm the Chief Program Officer for NC Med-Assist.
I want to thank you and welcome everyone to our committee meeting this afternoon. You have two outstanding presentations coming before us, but prior to introducing those two outstanding presentations, we have a little housekeeping to do, which is the approval of our previous minutes from last month. You received those minutes electronically. Is there a motion that we approve those minutes?
So moved. Second.
Been properly moved in second. Any discussion? Hearing none. All those in favor say aye.
Aye.
All right. Opposed, same sign. Those minutes are passed. Two great programs. You hear a lot about the cost of medicine and its impact on citizens throughout the country, but more particularly, we'll have a presentation this afternoon in terms of what we're doing to try to mitigate some of that expense. Also, a presentation on early childhood education, our MEC pre-K program. We all know, all of the parents in here knows how entertaining and challenging sometimes it can be to have to go to daycare and have to pay for that. That is really expensive today for working families. And certainly want to talk about the county's efforts to support families in that particular area. So with that said, I'll recall on the deputy county manager, and that is Anthony Trotman, to introduce these two presentations.
Well, Commissioner, thank you for you did a great job introducing them yourself, but I will say a little bit more. These are two board priorities: access to healthcare as well as early childhood education. And it's important to us that we make sure this committee is aware of its investment in your priority areas. So the first presentation will be from our NC Medicine organization, Nicole Stanfield. Please come to the mic.
And welcome.
Hello, can you all hear me? All right, well, good afternoon, everyone. Once again, my name is Nicole Stanfield. I am the Chief Program Officer for NC Medicine, and thank you so much for Mecklenburg County supporting us for many, many years, but we have been operating in this county serving individuals who are struggling with medication access for more than 26 years. And today you get to hear a little bit more about pharmacy and all of the things we're doing to make sure people have equitable access to medications, but also the various programs that we have been able to grow over the last 26 years. And I have been at Medicis for a little over 10 years now. I started right after I finished grad school, and we have had extreme growth in just the 10 years that I have been here. And everything I mentioned or go over today will be from our past fiscal year. So the fiscal year that ended in June 30th of 2023. Looking down. It's not working either. Okay. Okay, now that we have that technical issue solved. So if you're not familiar with us, NC Medicine is North Carolina's only statewide nonprofit-free pharmacy. So we are the only nonprofit in the state that is helping people access free prescription and over-the-counter medicines every single day through our various programs. We not only need the help of our technical clinicians, such as pharmacists and pharmacy technicians, but we also have social workers on our staff to help patients actually enroll into the program and access additional resources that they may need. So they may be struggling with other social determinants of health, so we can refer them out. But we also have an outreach team to be able to help the community learn more about what we do. Some of the outreach team members are patient-facing, so they actually go on site at some of our clinics and help patients get enrolled. And some of our outreach team members are more clinical-facing, so they're educating providers and letting them know about this resource and what they need to do to make their patients or help their patients get enrolled. We have served more than 18,000 individuals in Mecklenburg County last year alone out of the 73,000 we've served across the state. But we cannot do everything that we do without the collaborations that we have all across this county. So when we think about all the programs, we want to make sure we get medicine into the hands of as many people as possible. But in order for us to do that, we have to collaborate with the healthcare clinics here, the free clinics, the FQHCs that are here, some of the other organizations that interact with us through our mobile free pharmacy and OTC programs are a big help with that. Second Harvest Food Bank, if you were here at our luncheon, some of you all were here earlier, and we all ran over here to come to this meeting today. Second Harvest Food Bank of Metrolina gets a lot of the donated medicine products to us every single week. So we have to work together in order to make sure people are getting medicine, but we also want people to be able to access the other resources that they may not be aware of, but they know about us. So I will go over our prescription program first. This program is for people who are only uninsured. They live in North Carolina and they are lower income. So they have to meet that income guideline, and there is an application process. While we served over 2,000 individuals with just this program last year, 69% of the medications that we dispensed to our individuals in Mecklenburg County were just for covering the 4 chronic diseases. So when you look at high blood pressure, high cholesterol, asthma, diabetes, those top chronic diseases, the majority of medications that we dispensed were going to those chronic disease treatments, but we also help patients access women's health medications and behavioral health. So that's just a snapshot of some of the various medications that we are always giving out. On average, the value of prescriptions that we provide patients is over $4,400. But if you were at our luncheon today, usually around $200, if you donate that to us a year, will help that patient for their medications for one whole year. So we are able to make sure that return on investment is very large. And one of the great things about our program, the way that we're able to serve so many people, is because we are actually mail order. Most of the patients in Mecklenburg County are receiving their medications mailed to home. They don't have to worry about coming to our pharmacy. They don't have to worry about how to get on the bus and come all the way over there or find transportation. We do have a very small percentage of people who are coming in, and usually those are individuals who may be at Charlotte Rescue Mission or some of the other shelters or rehab centers where they bring everybody all together and they pick up their medications. When you're looking at our demographics, the majority of the individuals in our program are actually Black, Indigenous, or persons of color, and the majority of the people that we also serve are also women in the program. We also serve mostly adults through this program. We have very, very few children that enroll, but mostly it's because children usually have Medicaid or access to Medicaid, and most of the medications that we dispense are out in pill form. So just some more information about the prescriptions that we're also dispensing. When we're looking at the majority of the medication, chronic diseases that we've already mentioned, 62% of individuals in Mecklenburg County are actually receiving medications for treating high blood pressure. And then a little under half of those individuals are also receiving medications to treat diabetes. So those are our top two. So when we also look at our program outcomes for this particular program, one of the top outcomes we like to look at is medication compliance. And in pharmacy world, we have a term called medication possession ratio. And that is the ratio of time that a patient actually has their medication in hand. The average amount of time that you would like to see is 80% or more, because that means the patient is more likely to be compliant. If we see that Mrs. Smith is calling in her medication and she has a 90-day refill, but she's calling it in 100 days or 115 days later, that means there's potentially 15 days that she's gone without medication. And if she's not compliant, if she doesn't actually have it in her hand. In order for us to support medication compliance, some of the things that we do on the pharmacy side is we synchronize all of our medications. What that means is every single patient receives their medications with the same exact refill date. On average, NC Medicine patients take anywhere from 4 to 5 medications, so it's easier for them to keep up with. They don't have to remember lots of different dates for those different medications, and they can be more compliant. Another thing that we also do is primarily fill most of our medications 90 days at a time. That means they don't have to worry about calling in every single month, or on top of that, calling in because they have multiple refill dates. With 90 days at a time, it's only 4 times a year that they have to call in their medicines. And another great thing that we do in our pharmacy, but not every pharmacy does this, is we make sure our pharmacy staff contacts our patients when we see their compliance is low, or in the event that Mrs. Smith has 5 medications and she has called in 3 out of those 5, she will receive a phone call from one of our pharmacy team members asking her what's going on with the other 2. We may learn that Mrs. Smith may have had a medication that's discontinued, but she also may tell us, I don't like the way this one makes me feel. I don't like how it gives me headaches, or it causes digestive issues. And our pharmacists can provide that education to her about, have you called your doctor? Have you talked to a nurse? Have you told them about this instead of just not taking it? Because most of the time, our patients are connecting with our pharmacists far more than they are with their providers, and we can provide that information to them and let them know that. But something else I would like to share, on average across the United States, there has been a study done for the low-income individuals that we serve. Medication compliance is usually around 43%. So Mecklenburg County is above the United States average, at least for patients in our program. 2 other measurements we like to look at is patients who are in our program for a year or more. What we typically see is 80% of them are reporting that they are not going to the emergency room because they have been able to receive the medications from us. They're not worried about not taking it, or they're doing other risky behaviors such as sharing medication, taking half of their medication to stretch it out, which causes issues with them being able to be compliant. And then another thing we like to look at is overnight hospitalizations. So those 20% of people who may have actually gone to the hospital, even though they've gone to the hospital, 89% of them don't actually have to stay overnight because they've been able to be a little bit more compliant. And then the last number that we like to look at is we always mention healthcare costs avoided. We mentioned that at our luncheon earlier today, but we saved over $19 million in just this community alone because we're keeping people away from being able to go to the hospital. What that actually just means is those top chronic diseases that we look at, and it only includes those 4 chronic diseases that I mentioned earlier, with people who are able to stay out of the emergency room and not add in or incur higher costs, we're saving Mecklenburg County $19 million. And you also have to think about, these are all uninsured individuals. So this is uncompensated care. On average, it's about $1,500 for an emergency department visit. It may be more now that it's 2024, but if they're going there, no one's going to be able to pay for them and they're going to have higher medical costs. Some of the other outcomes I'd like to look at, this is a very, very, very small snapshot of a huge report that we receive every year. Dr. Jordan Lyerly at UNC Charlotte analyzes all of our patient data. So we do have surveys that come with our patient application, and she puts all this together in a huge report. But these are just 5 bullet points that I wanted to go over. Once again, patients who are in our program for longer than a year are more likely to be taking their medications as prescribed. They're less likely to be going to the emergency department. They're less likely to have overnight hospital stays. But also, when you look at a Likert scale and the statistical averages that we have for that, most of our patients who are in the program for longer than a year also report lower emotional problems and lower issues with struggling to cover basic needs. So they're not worried about purchasing food or medicine or keeping their lights on or paying their water bill just because they have to be able to afford their medicines. So part of our program also serves over-the-counter medicines. As I mentioned earlier, our over-the-counter medicine program is an umbrella. So the first program within it is our mobile free pharmacy program, also called free over-the-counter medicine giveaway events. What that means is in our over-the-counter medicine program, anybody who comes to the store or comes to one of our events must be 18 or older, but they're able to access the things that you would normally buy on the shelf. So allergy, pain, children's medicines, vitamins. People want to be able to get those things, but right now the costs are just too high and they come to us. What we do with our mobile free pharmacy program is we usually partner with a funder and several community partners to be able to bring the events actually into the community. So bringing our OTC medicine from our warehouse and out into the community. What we also like to do is make sure people have access to additional resources that they may not even realize are available. So we partner with other organizations to provide health screenings or vaccinations or medication disposals or lock boxes and anything else that they might need. And just right here, I have listed just a snapshot. Caring has been very gracious to us by providing health screenings at a lot of our events. Usually we host an event at Renaissance West every December, and Promising Pages gives away books, adults and children's books. We always run out in the first few hours. And Mecklenburg County Public Health has been able to provide information about tobacco cessation, and COVID-19 vaccinations have been able to be given out. We also want to make sure when we host our events, although Charlotte, North Carolina is our original home, this is our home office for everything, but we want to make sure we're not going to the same places all the time. So last year we had 9 events, but we served 6 different zip codes. But when you look at those 6 different zip codes, one of them is in Pineville. Some of them are in 28208. Some of them are in Northern Charlotte. So they're in various different places, but they serve different populations as well. And we served over 7,000 individuals in Mecklenburg County through that program. When you're looking at our demographics over here, the majority, once again, are Black, Indigenous, and persons of color who are attending our events. Again, it's mostly women. And we do see a higher number of Medicare and Medicaid recipients coming to these events, as well as our uninsured. That's typically because when you think about seniors, they are on an income that they are not able to stretch out a lot, so they can come frequently or they can come every time they see an event. But we also see a little bit younger group coming to these events, probably because most of our events are on Saturdays. Parents who want to be able to come and get medicines for their children are able to come at these mobile events versus when our store is actually open. Oh, one thing I will also mention, our demographics here for race and ethnicity, This is compiling all of the 9 events that we had last year, but when you actually look at each individual event, some of the differences you will see when we host an event at Renaissance West, the demographics are going to be heavily with the Black and African-American population. But when we host an event in Camino during the summer, we'll also see a higher number of Hispanic or Latino individuals. When we host an event in East Charlotte at a mosque, in a community center that primarily serves the Muslim community, you'll see differences there too. So this is just all encompassing, but I wanted to make sure I mentioned that. With our over-the-counter medicine store, this is our store we've been operating for 5 years. Fun fact that was not listed on here that I forgot to include. If you're not familiar with us, we do also operate a transitional jobs program here at NC Medicine, and our associates in the store are actually in that program. So they operate our store in our warehouse, and they're behind the counter helping clients who are coming in to get medicine, but they are there for 4 to 6 months to on-the-job training. And these are individuals who may have barriers to employment. So they may have been out of work for a while. They may have been previously justice involved. They may be seniors who've been out of work for a while and want to learn some new skills. But for our free store that we do operate, you must be 18 and older to receive the medicines, but you also have to provide a form of ID. Now, we also want to talk about equity and barriers. So when we say ID, we are very, very loose with that. We just want to make sure we have something to put patients, or clients, should I say, in our system, because they can only come shop in the store once every 30 days in case they need us. Our store served over 8,000 individuals last year, and it is located next to our offices and pharmacy in the 28208 zip code. But we only operate 3 days a week for a few hours. So we serve that large number of people just during that short amount of time. And that is individual participants and not store visits. Some of them come a little bit more frequently than once a year. Our top OTC medications that we're always looking at and people are always looking for are pain and fever, cold and cough, and digestive. And if you ask most of our clinicians, those are the top minor or ailments that can be, those are the top medications that help with minor ailments that will also keep people out of the emergency room. So what we see is if maybe a parent has a child that has a fever, or maybe they themselves have a fever, or a senior who is on an income that they cannot stretch out their income very much, what they'll do is actually go to the emergency room. What we also know from some of the data that we have been told and read from the Consumer Healthcare Products Association is 82% of people who do have OTCs would go to the emergency room if they did not actually have one in hand. One of the other great things about our store is we also have some durable medical equipment that we cannot take actually into the communities through our mobile free pharmacy program. So sometimes individuals may get wheelchairs, or maybe they're looking for glucometers or other DME that they might need. One last thing I'll mention about our store, in addition to our mobile free pharmacy and with people having access, some of the things that we like to do is use our store as a hub. So this happened this fiscal year, so it's not listed on here, but I just wanted to mention it. In addition to people coming to the store, sometimes we may host an event. So back in August, we partnered with the Lions Club, and they provided free vision and hearing screenings. And then later on, we partnered with another organization to provide a food giveaway. We partnered with Walgreens to be able to give free flu vaccinations. So it's not just people coming to the store, just like our mobile events, they're coming and actually getting additional resources. And this is just some information about our OTC store with our demographics. Once again, we are primarily serving minorities through our store. We see a lot more individuals who are uninsured and Medicare recipients, but another demographic that we'll point out is majority of individuals, regardless of age, gender, race, and ethnicity, that are coming to our store have a lower income. They're making under $35,000 a year. So these are the most low-income individuals in this county coming to our store. And lastly, this is our information about our over-the-counter medicine program. So this is encompassing of our store and encompassing of our mobile free pharmacy program. The value of over-the-counter medications that we dispense has been over $1.2 million for just Mecklenburg County. And what that actually goes to with healthcare costs avoided is we are keeping about $586 per person out of the healthcare system for uncompensated care. And one of the things I wanted to mention, just so we could add some real data other than some of the evidence-based data that we have used to create some of these measurements, what we wanted to do is start asking people when they come to the store, when they come to our mobile events and they get registered, Have they or someone in their household actually gone to the emergency room in the last year, but it could have been prevented if they just had an over-the-counter medication in hand? So when we started asking this question, I think we were only able to ask at 2 events. And out of the participants that said yes, it was 106, and that led to $159 of cost that is being avoided to our local healthcare system. Now that that question has been added on all of our information, we have some more information about how people actually use the medicines that they've received from our over-the-counter store or from our mobile free pharmacy program. But we are going to be able to see some real information coming out of that this year. And that is it for my presentation.
Ms. Stanfield, I certainly am just fascinated with this. Is something that is new for me. I'm sort of generally aware of it, but certainly you provided a lot of more specifics. So I really appreciate that.
Thank you. You're welcome.
I'm going to see if my colleagues, usually we kind of take both presentations, but since they are so different, I'm going to see if we can discipline ourselves to see if we can stay focused on this one to get some good questions for you. So let me see if my colleagues have questions. I'll start to one closest to me.
Okay.
Commissioner Meyer.
Thank you very much. And thank you so much for the presentation. I was just at the luncheon and the presentation was phenomenal. And I hated that I had to leave because he had amazing statistics and things to say. I would love to see those, to be able to see that again. By any chance, do you know if that's going to be available since I didn't get to finish?
Yes, in the background, we are actually working with Dr. Lugo to provide kind of more like a round or fireside chat with him, because before we had the luncheon, we met with him and gave him a tour of our facilities and just sitting down. I know you all got to hear the keynote. I left a little bit before he started speaking, but the data that he has and just the knowledge that he has around everything. And when we were asking him to speak and he was asking a lot of questions, he is really looking at all of that and getting much more familiar with Pharmacy World, because everyone isn't always familiar with that. But that will be coming out soon. We will announce when we are able to do that, but we do want him to we'll talk a little bit more in a smaller setting versus the large luncheon today about what he discussed with the keynote.
That would be great. Just a couple of questions. I noticed you have their income range on your statistics, but do you turn anybody away?
No.
Because of income?
No.
So there's not necessarily an eligibility, you're just doing it for information purposes?
Yes.
Okay.
Yes. For our over-the-counter medicines, we don't have an application process or anything like that. The application process is only limited to prescriptions.
Okay. And children's medication is included?
Yes.
Okay. And how do you communicate to the community? And I'm sorry if you covered that and I missed it.
No, that is fine. So when we have for our free pharmacy program, a lot of our patients in our program are referred to us through clinics or the hospital system or things like that. But our community-based employees are probably the best because they can be patient-facing and some of them are clinical-facing. We attend a lot of community health fairs. We're always going to as many things as we possibly can. Facebook is also one of the best uses. We also have a text message system so people can get information from us as well. We adopted that in 2020 and it has been phenomenal with being able to keep up with patients, but we utilize a lot of different avenues for that program. But for our over-the-counter program, when we look at our mobile free pharmacy events, some of the work that goes into setting up that event for that day is we have a committee for every single one of the events. The committee works together 90 days before the event, and those committee members could be other nonprofits, other health focused or organizations, or like I mentioned, Promising Pages was the one that always comes to Renaissance West. But we get a group of people together and they also help us promote it. So they are giving flyers out to their patients. We are promoting it to participants that have previously come. We're putting out information on Facebook. But now that we've kind of have our own mailing list, we utilize our text message system more than anything, because it is really helpful and people can remember. We do have a limitation to how many people can register before an event, because if we leave registration open, it'll probably hit 1,000 and we just can't fill all those bags with the many volunteers that we get. But that's primarily how we utilize communication. Facebook, even regardless of age, we see the data says a lot of people still use Facebook.
Interesting. That's interesting. One more thing, just one more. Okay. One more observation is like 75% of your customers are women.
Yeah.
I imagine a lot of single moms. You're
Single moms and seniors.
Okay.
Seniors. If you were to come into our store on a day that it is open, you will see a lot of seniors that are women in the store.
And maybe men don't go see doctors as much, or, you know, I don't know, seek out medical help. I don't know. I'm just saying, it's a good observation.
Well, we've had that conversation, and you were at the luncheon. Dr. Page, who's on our pharmacy committee, has talked to us about that. Some of the things that we'll have to do on our side is finding other avenues to get more men to come out, because sometimes they'll get the information, but they don't always utilize the information. Or sometimes we know that some of those senior women that are coming are married and they're getting stuff for their husbands as well, or their partners. So we do know that happens. And then the moms are getting everything for everybody, the children and the husbands as well if they're married.
Hardcore, Commissioner Meyer, hardcore. Commissioner Powell.
Thank you. Thank you for your work and your presentation. So a couple things. I really was glad that you talked about the emotional stress of what people are going through with chronic illness, because not only is there emotional stress, but there's the concern about affordability of not just your medicines, but your health care. And so I'm interested to know, I think that one of the reasons you're seeing success is because of the touch points, because of the human to human interaction. I'm curious to know, who are your major funders and major source of volunteers?
So for Mecklenburg County is one of our biggest funders, but we also receive a lot of funding from Leon Levine Foundation, the Duke Endowment. We have Atrium Health. We keep mentioning the luncheon. They were one of our biggest supporters. They fund basically every mobile free pharmacy event in the Charlotte region. So they partner with us to fund not only the OTC program, but also with our free pharmacy program. And with our volunteers, we have a volunteer manager who has done an amazing job of making sure a lot of those corporate relationships that we have also translated into bodies in our warehouse helping us sort or actually coming to our events. So one of the things that our committee is also tasked with whenever we have our mobile free pharmacy events is actually recruiting volunteers as well. So when you come, I know I keep urging everyone, if you ever want a tour of NC Medicist, you can please come. But we always have volunteers that are students coming in there, corporate individuals, or sometimes just groups that just want to be able to give back. And they've heard about us, whether through the luncheon or coming to some of the other events. But the biggest supporters that we have are the county, Duke Endowment, Leon Levine Foundation, and just individual donors, and then the hospital systems.
Thank you. And I just want to, if you need more, push the hospital systems.
Oh, yeah.
If Commissioner Meyer came to Medicist for medicine, could she get it?
Well, what kind of medicine is she looking for?
No, like the reason I'm asking is you said we don't turn anyone away.
For over-the-counter medicines, yes. We do not have any limitations or asking whether someone is insured, because just because someone has insurance, that does not mean that they may be struggling with their income at home. That does not mean that they may be struggling in other ways that we're not aware of. So we do not turn anyone away because they may have insurance. Now, I will tell you, for our free prescription program, because it is just for uninsured individuals, people who are over income or people that don't qualify for our services, this is why we have our social workers, they are able to get information from us. So what they can do is call, and based on what medication needs that they do have, we can refer them out. There are actually other national nonprofit pharmacies that are mail order that may have lower costs than regular pharmacies that people just don't know exist, but we know it exists. And a lot of the pharmaceutical companies that provide us with the free brand name medications that we do receive, they operate what we call in pharmacy world, patient assistance programs. So they're helping individuals also get medications, but a lot of their income guidelines are much higher than ours. So ours stops at 300%. A lot of theirs goes to 400%. So if someone is over income, we can say, hey, you can go directly to them. Here's the application. You need the same exact information as us. We already have this, but you can actually utilize them as well. So we have all the resources and know where to send people, but they just need to come to us, regardless of whether they actually think they qualify for one of our programs. They just need to call us.
I appreciate that, because it adds another touch point and assistance. And then my last question is, how do you know who's coming to the mobile free pharmacy if, you know, you said you weren't real picky about which ID was presented, because I do know of people that won't go that need it because of the ID thing.
So the ID is only for the store. We do not ask for ID for our mobile free pharmacy event.
So if they come to the mobile free,
Right.
there's no ID required.
That's correct.
All right, that's what I need to know.
We only assume everyone does have to be 18 or older. If you look like you might be under that, we may ask for ID just for safety purposes, but we do not ask for ID generally.
But it's just like Advil and Tylenol, right? It's not.
Yes, but people can find ways to abuse certain things anyway.
Oh, wow.
Yeah.
Okay, thank you.
All right, let me
Welcome.
see if my, the colleague.
Thank you, Mr. Chairman. I do have a question. This has come up a couple of times when we've had some nonprofit medical centers come and talk about pharmacy. You know, they have like I know Charlotte Mecklenburg Community Health Center, CMHC.
Charlotte Community Health Clinic?
Carolyn Allison's group.
Yeah,
They were
Charlotte
trying
Community
to,
Health Clinic.
yeah, they were trying to, and I think they have raised money, and they don't have this need now, but they did have a need, and they were trying to make a pharmacy in their location. And so I just wondered if you guys already do that with some locations, like where you would be located in a free clinic, or you know, a place that's where folks might be needing your prescription drugs.
So I will mention, that's a good question. People ask us that all the time. We work with not only free clinics, but also a lot of federally qualified health centers, which Charlotte Community Health Clinic actually is.
Right.
Although they may be opening their own pharmacy, and we are aware that they're doing that, there is still a greater need than even Medicis can just serve. We also have a very, very structured medication list to make sure that only the highest used medications are on our list. I went over a lot of the information about our program, but some of the information that is not in here is the majority of the medications that on our formulary are generic medications, which we purchase about 88% of it now. 10 years ago, it was 75% of it was free donated drugs to us. So we have to make sure we're doing everything to keep our costs down, but we're also limited. There are some medications that we just do not have. We do not have controlled substances. As I mentioned before, we don't serve a lot of children in that program because we don't have a lot of liquid. We don't have any liquid medication. So a lot of reasons why we see children in our program every once in a while is because they're trying to get inhalers. And half of our budget this year, or more than half, has actually gone to just purchasing inhalers. A few years ago, one of the pharmaceutical companies that was giving it to us completely in kind, it's no longer available to us for free. But taking away inhalers that people need immediately means people will go to the emergency room. So our board has made sure they have kept that on the list, but the cost just keeps growing. But we want to make sure people also understand there are enough people going around that still need help with medication, and whether they get it from us or they get it from somebody else, at least we're all working together. And some of the things too, with a federal qualified health center, they're required to help individuals who are also uninsured and insured. So we cannot, through the free pharmacy program, help people who are insured so they can go to an FQHC or like Charlotte Community Health Clinic once they have theirs open. But there is a cost to that. It is not free. And then for our uninsured individuals, we work with probably every major FQHC in the state of North Carolina. They still send patients to us because if they're uninsured, they are more than likely not be able to purchase the medications that they will be able to get from that FQHC pharmacy. So we all still have to work together. And the group that we serve is uninsured individuals, and that's not going to change.
Okay, so just one last comment is that the thing I was so impressed with today with the keynote speaker was that he really spoke truth to power. And the title of his presentation was, it had to do with political determinants of health.
Right.
And I was so impressed that he just went straight for it and talked about, I mean, literally, I think what he was saying is that, you know, we are part of a system that denies people healthcare, and we all are. And so anyways, I was just really impressed that he went there. So thank you for that. I hope we get to see his keynote in another format so that we can, take that in. So thank you very much.
You're welcome. And I think everything was recorded today, so we should be able to send it out. But I left before he started because I didn't want to get up since I was in the middle of the room, but he did have that conversation with us. So we knew that was going to be something. And if you just Google Dr. Aluko's name, that is going to be a phrase that comes up associated with him that you don't hear very often.
It was excellent.
All right. I'll give my colleagues one last shot at the apple. A quick question and a quick answer. Because I want to give Tim his appropriate time, because childcare, pre-K is very important. So
I'm good. You answered everything. Thank you.
All right. Other colleagues?
I just want to say thank you for talking about the inhalers and for funding that, because when I moved to North Carolina in 1986, I had never seen such an incidence of asthma. And I want you to know that we're doing our part in environmental stewardship to make sure we keep the air clean. But I know you're doing your part to make sure everyone can keep breathing. Thank you.
You're welcome.
Just good. Just you've been there for 10 years.
Yes.
And the program's been around for 26 years.
Yes.
And just adding up your numbers, you had about 18,140 in terms of your free clinic, your mobile, and your free store. Have you seen over the 10-year period an increase? Has it been about stable the last few years? What is your experience in terms of participants?
Depending on what program you look at, so our store has only been open for 5 years.
Oh.
Our over-the-counter medicine program actually started in 2012, and when I started in 2013, it was just a closet. And we moved out of the Children and Family Services Center, now Ascend Nonprofit Solutions, because the over-the-counter medicine program was growing so much. And when we hosted events for Mecklenburg County to be able to get medicine, we were clogging up the elevators. Second Harvest Food Bank is making deliveries and messing up the nice floors and elevators trying to come to the 3rd floor. So now we have a warehouse where we're able to host that. So that has had immense growth. Even in 2020, during the pandemic, when we moved to having a drive-through version, our service to individuals needing over-the-counter medications more than doubled. So we know people want to be able to take care of themselves at home. It's just that they have no way to be able to afford that. And they tell us that all the time. And that's one of the events where we get to face with everyone, and they share that information with us. When it comes to our prescription program, we have seen a decrease in the prescription program over the last few years. Some of that could be attributed to, we unfortunately, in the last few years that I've been there, we've had a lot of pharmaceutical companies that no longer have certain medications available, and they just can't get it from us. Somebody may be coming to us, I will say, I think this was maybe 2017. AstraZeneca used to be a brand name or a brand name pharmaceutical company that we gave out a lot of medications to. They took 13 medications off their formulary. And we could not afford to keep all of them on there. So some people were just coming for those medications and they can't get it. A lot of the changes and struggles with being able to access medication, it hasn't gotten any better, even when we're purchasing medications and since the pandemic. And then some of the, I will say that some of the needs with diseases has also changed. We also have, may have those major chronic diseases that people need, but the cost for us to be able to keep a robust formulary is just getting a little bit too high. So that may prevent some people from being able to come there. But I will say the income levels have gone up a little bit more too. So our income guidelines 10 years ago, and even a few years ago, actually used to be 200% of the federal poverty level. We moved it up during the pandemic because we saw so many people who were just over it a little bit, by a few hundreds worth of dollars, and they couldn't be in our program. So we moved it up to be able to capture those individuals. But we have to do more work with outreach, and we've been able to, fortunately, the Duke Endowment, our community outreach positions that we have now, the Duke Endowment has funded 2 of them for the last 3 years now. And we've been able to see a lot more growth come out of having them being face-to-face with clients in clinics, going to where they actually are, versus just giving out information and hoping they know about NC Medicine, hoping that that doctor actually told them about medicines if they're needing medications. So we're leaning more into community outreach because we have to, and knowing that we also cannot just utilize doctors either. We have to be able to go to where the people are. So if that's more events at churches, if that's more events at some food pop-up, we'll be able to do that. And we're leaning into that.
Ms. Stansfield, this has been quite enlightening for me. And certainly I'm going to take you up on the invitation to come and visit.
Sure.
And thank you so very much for your presentation. And to staff, thank you. This is a new, I'm sort of aware, but this has been very informative for me as chair. And Anthony, this is great. Thank you.
Well, great. Thank you, Commissioner. And our next presentation is Tim Gibbons. This is has been an important topic for the board for a number of years, and definitely look forward to Tim's presentation.
Yes, thank you, Anthony. Good afternoon, everybody. Thank you again for having me here today. As Commissioner Griffin alluded to, and then Anthony referenced, there were two items that I wanted to come before you today to share an update on and hopefully answer any questions. The first relating to ongoing discussions and questions about sort of how our children in MEC Pre-K are performing when they leave our program. So I wanted to go through and highlight, when I've had a chance to speak before you before, we've shared a lot of information about what our children are doing within the program when we have them, but wanted to share both what are we currently doing to track some of our students long-term, and then where do we have some challenges related to some questions that have continued to come up that we're trying to get answered. And then secondly, what I wanted to hit on was just a brief update on our expanded eligibility child care subsidy program, which was rolled out to help address some of the benefits cliff issues that some of our families were bumping into. So before I jump into some of the information on student tracking and data that we're gathering, I think there was a preliminary question just related to some of the demographics and breakdown of the students in MEC Pre-K. So I did just want to hit a couple quick items related to our currently enrolled students in this school year. One of the things that we've prioritized as long as I've been involved in the program was really trying to ensure that we're reaching a diverse population, but also making sure that we're prioritizing getting those children and families who have the greatest need into the program. So when we talk about diversity across the program, I know race ethnicity is kind of the first thing that comes to mind. And so the breakdown that you can see there, you can see the two biggest groups that we have that in total adds up to about 3/4 of our students are identifying as Black, African American, or Hispanic in the program. But beyond just race ethnicity, we know there's a variety of other dimensions that can comprise diversity within the classroom or within our families. So some of the other data points that I've highlighted here, and there's plenty others that we could look at, from language to family education, employment, et cetera. But we do take a look at families when they come into the program. And I would estimate that this is probably underreporting, because we do have some families, I think, that are afraid to be honest about some of the challenges their children have for fear that they won't be placed. But we do know coming into the program this year, almost 12% of the kids that are currently enrolled, their families identified they were currently receiving supportive services. So that could be physical therapy, occupational therapy, speech, a variety of other support services that could be there. And of course, we really raise that number once we get a chance to screen children and get our hands on them as we work with them. And then when we take a look at household income to look at the different socioeconomic status of the families that we're working with, you can see, in terms of sort of where a lot of our classrooms are located, the predominant number of our children are coming from families that fall below 200% of the federal poverty level. So even though over the years we first lessened and then fully removed the income cap on the program, we are still getting out there and reaching those families that have the greatest need or may have difficulties accessing or affording other childcare or early education arrangements. So again, just wanted to provide just a little bit of context about what our children look like here to start. So over these next couple slides, what I want to get into, of course, when we have children that come within our program, we collect a variety of different measures and information on them in terms of child development throughout the school year while we have them, amongst a range of other data points that we gather. But beyond that, we've been engaged with an independent longitudinal study to track how our children do when they leave the MEC Pre-K program. As much as we are always proud to come before you each year and share sort of what the data is telling us about how children perform each year that we have them, I think we do also still have those loftier goals that while we want to see the impact that we can have on families, that Commissioner Griffin alluded to start the meeting about affordability and access, and what we're doing for children while we have them, I think we also want to say we're setting them up for long-term success. And we want to hold ourselves accountable to see where we're doing well in that regard and where we can still improve. So what this looks like currently for us, just to clear up any confusion with how this functions. So we've been engaged with an independent organization, High Scope Educational Research Foundation. For those who don't know, they're kind of the gold standard in this field. They conducted the first longitudinal Head Start study that they're very famous for. They're based out of Michigan. And so what they're doing is they're tracking 3 cohorts of our MEC Pre-K students, and they're going to be following each of those cohorts as they progress through CMS all the way through 5th grade. And so you can see from this table in the top left up here, cohort 1 was in MEC Pre-K last year, and they are currently enrolled in kindergarten right now. Cohort 2 is currently in our MEC Pre-K classrooms, and then cohort 3 will be pulled from students that are enrolled in MEC Pre-K next year. And as you get through that, as you look to the right there, when we talk about a cohort, so cohorts consist of approximately 180 to 200 students. That number may go up with our cohort that we pull next year because we may oversample a little bit. And those cohorts are pulled from random sampling. So the evaluators are randomly selecting MEC Pre-K centers. Within those centers, they're randomly selecting classrooms. And then within those classrooms, they're randomly selecting students. And then once students are initially pulled through that random selection, families then have to consent to opt into the long-term evaluation. The whole evaluation is being run and operated under institutional review board protocols to make sure that we're doing and conducting ethical research on human subjects. And then as our students, as we move into CMS, the evaluation team is actually working with CMS and elementary schools to recruit a control group of students who did not attend public pre-K. So we have a control group to measure against how our MEC Pre-K children are performing. So again, it's not just looking at our children, but trying to look at them in concert in terms of what a control group may look like. And then, as I mentioned, those students are all going to be tracked through 5th grade. So when we talk about tracking, what does that look like? In the bottom in the green little box down here, during the preschool years, what those independent evaluators are looking at, they're measuring program characteristics to see what our program looks like. So they're taking a look and looking at what do our directors of our programs looking like, demographically, education-wise, across a host of different dimensions. They're looking at what our teachers look like that are part of the classrooms for our study. What do our families look like? They're measuring classroom quality with a tool that they have. So they're going in and evaluating the quality of our teachers in classrooms and providing recommendations on areas for improvement and flagging places that we're actually performing quite well. And then specifically taking a look at child development in pre and post settings. So I've listed here a variety of assessment tools that they're using or specific things that they're measuring in terms of skills that our students are developing. And then during the CMS school year is what they're going to be looking at in terms of the approved research proposal that they have. They're going to be getting data from CMS on attendance for students, discipline, their grades and performance in terms of how they're moving through, and then ultimately child development. So looking at those EOG scores, and then before they get to some of those grades that have those EOGs, they're looking at other literacy and math assessments to assess how those children are performing on developmentally. So this is what we have ongoing from a longitudinal evaluation standpoint. And so I wanted to start here because I know there's been questions and concerns about what can we access related to all of our students. So I wanted to be clear about what we are doing. And then I'm going to shift a little bit into sort of what are the challenges we have right now about getting data on all of our students. So the big challenge that we have outside of the valuation in terms of getting data from any of our students that go into CMS is primarily a logistical one. And that is CMS doesn't really have a way right now to identify which of the children were enrolled in MEC Pre-K. And so what I've mapped out here is just to kind of lay out logistically sort of and operationally what things look like when children enroll in public pre-K programs and then when they roll into CMS to show you where the disconnect currently exists. So all of these red circles and boxes up here represent things that CMS has visibility into. And the two green ones at the bottom are what we at MEC Pre-K have visibility into. So starting at the far left here, when students enroll in a CMS public pre-K program, which is Bright Beginnings or NC Pre-K, when they go through that pre-K enrollment process and are placed, they're assigned a CMS ID. And that CMS ID, when they enroll in kindergarten, follows them from pre-K into kindergarten and then from first grade through senior year of high school. They've got the same CMS ID all the way through. So they have a unique identifier the second they enroll in pre-K that they're able to use to identify students that were enrolled in their pre-K programs from the start. So when they want to take a look back, if they look recently about how their pre-K students perform in kindergarten, they can easily use that unique identifier to filter those kids down there. The challenge that they have with our students are when our students enroll and come through MEC Pre-K, they come through our system and they're assigned a unique MEC Pre-K ID. But it's not until they're enrolling in kindergarten that they get that unique CMS identifier that those other pre-K students get when they're in pre-K. And so that right there is where there's the disconnect where the two programs and systems do not speak to one another. So when their students and our kids enroll in kindergarten and go beyond, CMS knows that what their CMS ID is, but they have no way of knowing if they were enrolled in MEC Pre-K. And from our standpoint, we have no way of knowing what their CMS ID is. So there's this disconnect that, again, it's not insurmountable, but that's where we have the logistical challenge right now of easily being able to pull that information. So we've been working with the CMS team to try to come up with solutions to address this. The number one thing we're trying to solve for right now is to ensure that our evaluation team can track all of the students enrolled in our evaluation program first, and then seeing what we can do to solve the bigger picture, if possible, for all of our students. So logistically, again, things that we've talked about with them, conceivably CMS would have to implement some sort of what we call a fuzzy matching process, which is sort of an iterative data process to try to link data sets when you don't have unique identifiers. Conceivably, may there be a way to ask on the CMS application if your child was a MEC Pre-K student. Again, that wouldn't be perfect because it's self-reported. And frankly, we know some families get confused about what program they were enrolled in. For our evaluation right now, we've tried to work with families to ask them for their CMS ID to see what kind of response rate and things that we get. So we are trying to find ways to solve for this so we can take a bigger look outside the evaluation. But I wanted to be clear about sort of what we do have and then what we don't have and sort of where the challenge is about why we don't have it right now. So again, just to be clear to wrap up right now, what we currently have or will have moving forwards, on the left-hand side, that first box is all types of data that we currently collect ourselves within the program. Data on enrollment, demographics, attendance, child development, support services, anything that's going on with a child by and large within the MEC Pre-K program, we can track. We've got data on that we can break out. And then from the independent evaluation team, what they're going to be doing is they're going to be producing an annual report every year, summarizing the findings for that past year for every cohort that's involved in the evaluation. So since year one and cohort one started in MEC Pre-K last year, the team right now is actually finalizing the year one report with some feedback that we gave them. And that should hopefully be completed sometime later this spring here. And then we'll figure out ways to share that information more broadly. What we do not currently have that I was highlighting is those MEC Pre-K students who are not involved in the longitudinal evaluation. That is where right now we do not have a clean way to link to anything they're doing in CMS. And I will just pause and caution too, if and when we can overcome some of those logistical hurdles, we're probably going to have to overcome some legal and privacy hurdles too to make sure that we've got everything buttoned up appropriately. Because our families involved in the study longitudinally, we've gotten their consent to get their data longitudinally. So again, I just don't want to overpromise on anything and have people who are much more smart on the legal side of things to confirm what we can and can't track with or without consent from our families. The second piece here that I wanted to briefly touch upon, I know there were some questions about our benefits cliff and expanded eligibility program for child care subsidy. So as a reminder, just to kind of start off with the program, the expanded eligibility program was created really to expand access to working families who were being locked out of accessing child care subsidy, which also included some families who did have access to subsidy, but they were going to lose it because they were hitting the benefits cliff. So there were three types of families that we were focused on. So there's sort of three prongs of the program that we look at. The first was taking a look at work hours. So for state subsidy, there's pretty stringent work hour requirements of 30 hours of work per week. I believe it's down to about 20 hours if you look at folks who are enrolled in secondary education programs. But even then, there's some strict restrictions on that. And so what we were finding a big challenge for families was there was a catch-22 for some of these families, that they needed 30 hours of work a week to access child care subsidy, but they couldn't work 30 hours a week unless they had somewhere safe to put their child, which they couldn't afford because they couldn't get subsidy. So the first thing that we took a look at was lowering the work hour requirement in this program to 22 hours per week to allow people to get access to subsidy so they could hopefully get themselves a leg up to finding better and more stable employment. The second piece was taking a look at a benefits cliff. So there is some wiggle room in state subsidy. And again, just for context, state subsidy for income requirements are for children 0 to 5 is 200% of the federal poverty level. And for school-age children, it's 133% of the federal poverty level. So there are very strict income requirements for child care subsidy for the state program. And so there are some leeways of phase out that if families go over income, that they can phase out of state subsidy. But again, it's a short runway. So what we said was if we had families that were on state subsidy and they hit that benefits cliff, let's extend that cliff out all the way to 300% of the federal poverty level for them so they don't get kicked off. And then lastly, what we took a look at was families who were already over income trying to come in and access child care subsidy. But if they were coming in at 201% of the federal poverty level, they were being locked out and childcare still wasn't affordable for them. So we said, let's open the door up to make the pipeline wider to anyone who makes up to 300% of the federal poverty level. So those are, again, sort of the three prongs about which we kind of opened up to bring more families into this program. So in terms of the impact of the program, before I go through the numbers and all the stuff on the chart, just to kind of give you a sense of where we can get information currently. So for this program, like any other child care subsidy program that's administered in Mecklenburg County, families have to go through an annual recertification process. So once you get in and you get approved, your voucher is good for a year, but then you have to go through an annual recertification process to check in where you are at. So when we take a look at sort of how this program may or may not be impacting families, that point that we get a chance to do that is if they come through to recertify for that second year. And right now in the initial reports that we have from CCRI, we don't have, at least how it's broken out. We've started to get it for the last month or two, the very specific detail on work hours and income. So for future reporting, we should be able to provide more granular detail. But right now, what we can currently see quickly, at least for the purposes of this presentation, was did families come through from year one and recertify in year two? Yes or no? And if they did recertify in year two, what program did they enroll in? And by looking at what program they enrolled in, we can get some proxy information about how the family's situation may or may not have changed. So we're going to look at this two different ways here. The first is taking a look at families who are enrolled based on not meeting that 30 work hour requirement, if you remember that stream there. And so the data we're taking a look at here represents families who enrolled in year one during the first few months of the program. So this is families who enrolled in August 2022 through January of 2023. So again, that annual recertification process began in August 2023 through January of 2024. So that's where we're gathering this next batch of data here. So in this first batch of data that we had through this subsidy stream, there were 86 children enrolled who families qualified in this lessened or a little bit looser work hour requirements. Of those 86 children, for whatever reason, 38 of them, or 45% roughly, did not recertify for year two. They may have not responded to their recertification packet or outreach from CCRI. They may not have submitted all the proper information or documentation. It could have been a host of reasons why they may not have recertified. But of the 48 children who did recertify, we can take a look to see what program did they recertify for in year 2. And of that group of children, about 2/3 of them, we know based on where they enrolled, their family was able to increase their work hours and increase their income to go along with that. So the program, again, we can't say it was solely due to the program, but families enrolled in this program of who we have data for, many of them were clearly able to show an improvement in their work situation as they went into year 2. And then you can see at the bottom about that other third representing 17 children. In year 2, they recertified and were not able to hit the 30-hour work requirement again. The bigger bucket of children that we have here come from those other 2 work streams, those other subsidy work streams that were focused on expanding income access and eligibility. So this is, again, those families who were enrolled and hit the benefits cliff, or families who came in making up to 300% of the federal poverty level. And in this group, there were 258 children total in this first wave of analysis that we did. You can see 90 of them, or about 35%, did not recertify for year 2, while 65%, or 168 children, did recertify for year 2. And then again, this is a place where, while we're still trying to get more of the granular information, it's hard to just understand what change, if any, happened in the family's situation. So again, you can see 4% there, we know, increased their income because they came in over 300% of the federal poverty level in year 2. And then at the very bottom, we know 3 children recertified and they moved down to the program to qualify for less than 30 work hours. But the biggest bulk of the children there, about 94%, again, really sort of remained in this same subsidy stream here. So we're trying to get the more granular info to take a look at what that may look like. But again, we didn't necessarily expect any drastic changes with this group because 200% to 300% of the federal poverty level really encompasses a lot of like middle-class working jobs. And so I don't know that we expected necessarily to see sort of drastic changes in people's employment situation when, just to kind of give you an example of what that looks like, a new MEC pre-K lead teacher at the salary that we pay to start there, which is on the CMS salary scale, if that was a single mother with 1 child, would check in at about 225% of the federal poverty level. So if we think about programs serving families like that, again, not necessarily expecting them to see drastic changes in their employment situation because, again, those are stable jobs. It's just where they fall on the federal poverty level. So again, we are working to get a little bit more granular info on work hours and income to see how that changed. And so when we can provide another report out, we should have more data there that we get in some of those reports. And I'm sure there are plenty of questions, and I'll try to answer those as best I can.
Not plenty, Tim, just a few. Anyway, let's try to have some tight questions and tight answers because we'll probably have several rounds. So I started with Commissioner Meyer earlier. I'll start with Commissioner Powell this time for questions for Tim.
Thank you for your work. When we were going over this slide, number 6, it's just striking that we're making such a big investment, huge investment in pre-K. And I just need you to help me understand what are the legal hurdles, if you can, to keeping, like why does the CMS data on Mecklenburg pre-K students, why isn't it included? Like, help me understand that. Because we're making this investment, why aren't they required to participate?
I'm sorry, when you say like the students who are enrolled in Bright Beginnings or NC pre-K?
Really, like on slide 6, the right side, you say what we do not currently have is the CMS data on MEC pre-K students. Explain that again. Why don't we have it?
Because, so first off, when our students leave MEC pre-K, we don't know what their CMS ID, if they enroll in kindergarten, what their CMS identifier is. And CMS doesn't know if they were enrolled in MEC pre-K. So they don't have a clean way to delineate which of the students that they have in kindergarten were MEC pre-K students.
So, and I totally understand this slide. I get it. But it seems like such a simple solution. Like, what is it that, the families that had their kids in pre-K can't remember to tell CMS?
So I don't know that CMS currently gathers information on their MEC pre-K students. I don't know what their kindergarten application looks like now that they have an online process. We used to work with CMS in terms of getting their school IDs assigned while they were in MEC pre-K to smooth kindergarten enrollment. But once they moved to an online platform this past year, we lost that visibility as part of that process. So that's purely a conversation between CMS and the families on there. Like I said, that is something that we've talked about with them, conceivably, if that's could be added to the kindergarten application. But again, I don't know.
It's just shocking.
Let me steal 30 seconds of,
Okay.
20 seconds.
Okay.
What's the difference between NC pre-K, because they do get the identifier, and MEC pre-K? Is the NC pre-K is a state program?
NC pre-K, CMS is the contracting agency for NC pre-K. So all students enrolled in NC pre-K are going through CMS's front door. All the students in MEC pre-K are coming through our front door. There's two doors is the issue there.
Gotcha. Like, I'm sorry, but it's just the two.
It's so shocking. Like, we're all sitting here like whispering how shocking it is, you know, because it's such a big investment and such a simple solution. And I don't know if there is a legal hurdle, but if there is, help us understand it so we can help. It just seems like we have this huge investment. We need to know, is MEC pre-K valuable? And I'm thinking of like some of my very loud constituents that would be furious to think that we can't track this investment for MEC pre-K.
So, I mean, I completely understand. I think that's why we've tried to figure that out for all students. I mean, I would also say, again, if we could get all data, that would be fantastic. But I would also posit that the investment that we're making in this longitudinal independent evaluation is going to offer exactly what you're asking about, if this investment is valuable and if we are making the impact that we claim we are making with our children.
Thank you. Because I got a real sassy email recently that said, can you believe they're doing pre-K readiness? And I thought, wow, I think a lot of people don't understand what skills you're looking for assessing when people come to pre-K, and then the skills that are assessed in kindergarten. And so I took the time to try and help them understand it better. But I hear some backlash sometimes about this, how big this investment is. And then when you look at slide 10 on a different investment, I don't know, you know, it'd be nice to see how many dollars were invested in the 258 children. And then we see a benefit for, maybe I'm looking at the wrong slide. It's slide 9. So it's 86 children that we invest in, and we see that the families of 31 have been positively impacted. It'd be interesting to know how much was invested in that program for the 31 families. Do you know that?
I can't speak to specific investment per family. We don't get reporting to that level of detail. I may be able to work with CCRI to figure that out, but we report more on the aggregate numbers that we're spending on a monthly basis relative to enrollment and things like that.
So just one more question is that statistically significant to, out of 86, to see a positive improvement for 31? That's just a out loud question.
Tim's going to have to get back with
us.
All right,
on, thank you.
On that.
Thank you.
Commissioner Meyer.
I just want to reiterate what Commissioner Powell said. This is crazy that we can't track the kids, because I swear, as sure as I know my name, I was told that they would be assigned a CMS number right off the bat in MEC pre-K. What happened to that? And was that an assumption? Was that the plan and something happened? I mean, because I know that's what I was told.
Yeah, I don't recall. I just
I wasn't here, so
yeah.
It was that, and I don't know if you were, I don't know.
So as far as I know, so when they used to go through during kindergarten transition, The MEC Pre-K team worked with the CMS staff on kindergarten enrollment. They pulled together physical cumulative folders that followed the children. And as part of that process, we used to share rosters and we did get IDs assigned. This past year, for the first time, as CMS shifted to their online portal for kindergarten applications and the lottery and everything that they do, that shift is where that got broken. We don't do that for them anymore. All families have to go through that online portal or whatever the process is for CMS. So that was something that we uncovered for the first time with our evaluation team this year, that we thought we would have the IDs again, and we don't, because they've moved to a new kindergarten enrollment process.
So I mean, is it possible that CMS would agree to give them an ID right off the bat when they enroll in MEC Pre-K? I mean, I don't know why that would be a problem.
I can't
And I think
speak.
that's what Commissioner Powell was asking about, the legality of it. Is that a legal problem?
I can't speak for how CMS manages their enrollment processes, and I definitely don't want to posit anything from a legal perspective beyond what I know. I just know anytime we get into certain things about asking about our students that we haven't gotten prior consent for, is where you start to get into FERPA and other issues that I'm not saying it's insurmountable. It's just oftentimes there's things that we don't anticipate. So I think it's kind of two separate issues. I think it's more from a legal privacy issue, is more after the fact if we're trying to ask for information on families that have not consented for us to do so.
I think we can follow back up with you because I know this will come back up. So we will get you an answer on the legality of doing this.
Thank you.
Yeah, I think just posit your questions with the county manager, since the county manager has an excellent relationship with the superintendent, and see if we can work it through from that perspective. What I suggest. What is it? 2:15. All right. Commissioner Meyer cut you off, so you go ahead. You're good.
Yeah, that's it.
Commissioner Rodriguez McDowell.
I have a really easy one. What's the total number of children this year in MEC Pre-K?
So it tends to fluctuate a little bit, obviously, throughout the year, but we were up at about 1,800 children as enrollment this year, which was an all-time high.
Right. Okay. That's all for me. Thank you.
You mentioned the and HighScope really is a solid organization that I'm familiar with, and they did the original study at the Perry Preschool program in Delancey, Michigan, and really followed kids for 20 years or more. So it gave rise to the Head Start program. So they're a really quality organization. In terms of their evaluation of us, you didn't mention anything about that. Since we're in we completed year 1. Did they give you any feedback in terms of what we're doing? And what I mean by that, our classrooms, our teachers, our support materials, et cetera.
Yeah, they definitely went through. They provided sort of an abbreviated look in terms of their classroom quality evaluations to kind of highlight where we were strong and sort of where we had areas for improvements. And they built that into us over the summer so we could fill it into our PD. Again, without having it here in front of me, I'm going to be kind of grasping at stuff. I'm happy to follow up. I will say, again, they've got all the things in terms of student growth throughout the year. The big thing that we provided feedback on that we're just waiting for a more updated draft was it was very academic. And there wasn't necessarily a lot of context provided to say like, well, if pre and post numbers were this and this, what does that actually mean in a real world context for children? So that's what we asked them to go back in and add some additional info for.
Well, I know that would be valuable as we go through the budget process. If there's some things we need to do better in terms of supplying and stocking the classrooms, or in terms of professional development for teachers, that would be justification for providing additional resources to the program, at least from that end of it. So if that's available, would certainly like to have a summary of their first observations if they haven't completed those. I know evaluators take a moment or two to make sure all the I's are dotted and the T's are crossed. But if that's available during the budget process, that would certainly be helpful to Deputy County Manager. That would be helpful. Again, you've heard from the colleagues, one of the key pieces is return on investment. One of the pieces that HighScope has also done in terms of research When students leave their pre-K settings and then go to the other organizations, there's no guarantee in terms of the quality of that teacher in first grade or in kindergarten or in second grade. And when you evaluate third grade, you don't see the kind of things that you're looking for. That's why it's so helpful to be able to follow on both sides of the aisle. That is what we do and what CMS is doing. And if there are corrections that need to be made on either side, we need to make those corrections timely so that you get the results that you're looking for. If you have a program of a phenomenal pre-K program, but yet there are hits and misses in kindergarten or first grade before you get to third grade, you tend not to get the results you're looking for. But I think because of our relationship with CMS, clearly with K3, we ought to be able to have better opportunities and responses, I think, from this experience. So I really am excited about having the experience, but it's the quality of these services for our kids. And your presentation during the retreat was phenomenal in terms of kids who were excelling. I think Brigance or something, I forgot the name of the assessment instrument, but you demonstrated that when those youngsters are leaving you, they're leaving you at the highest level, most of them. It would be really nice to follow them in CMS in terms of kindergarten, first grade, second grade, and third grade. So colleagues, I think if we just raise this issue with our county manager, might be able to accelerate getting that information, tagging these kids, because NC Pre-K is still a subsidy program, right?
So it's free for families, state funded. Yeah.
It's state funded though, right?
Yes.
Yeah. So they have this relationship where they can get the IDs. We're state funded, we're taxpayer funded. I mean, funded by the county. So we should be able to get the same relationship, I think, with CMS. And that's not for you to answer. I'm trying to force don't answer, Tim, because it's not for you to answer, but it's a question we need to figure out. So really appreciate your presentation. I think this is, colleagues, if we can get this right, this is really going to have impact in terms of upward mobility if we can get this right. So, but we got to get it right. Powell, you wanted to say something? I can see your mouth moving.
I'd be a terrible poker player. I just want to speak to why, I don't know if you can hear the emotion, but I feel so strongly. In 1989, I was working at the hospital and Susan Burgess's husband was a doctor. And so we were working together and he was talking about how many children needed help. And I was single and I believe in community service. And so I thought, I'll volunteer. And so I was assigned to Eastway Middle School. And the first day that I got there, it's still so shocking to me. It feels like yesterday. They asked me to work with some seventh graders. And when I got in there, I thought I would just be helping them, understand things. They didn't know how to read. And it was so shocking to end up with a group of a small group of seventh graders who didn't know how to read, who were struggling. And I remember calling my mother that night thinking I'm not a magician. How can I help them in seventh grade? This intervention should have happened a long time ago. And so I feel like when we voted to fully fund the MEC Pre-K, I felt good about that because I knew that the interventions would be in time. But if we can't track it, it's just super frustrating. So, Commissioner Meyer keeps saying it's ridiculous. So that's it. We feel passionate. We want to know that this investment is making it not just return on dollars, but making sure that we're investing in human beings that are successful, and that we catch things in time. And so I wanted you to understand the passion, because sometimes, when you guys are giving a presentation, you don't understand where it's coming from, but I carry that with me. I volunteered in CMS for 25 years helping children who are struggling. And the intervention should have happened a lot sooner. Thank you.
Commissioner Powell, thank you for that passion. But I think this staff has received that message. We need to make sure that our county manager received that message.
Well, I really appreciate your work.
But these guys are, Tim's doing a great job. I certainly like the information that you're presenting. The information during the retreat was excellent. We just need to be able to follow that information. So before I ask for a motion for adjournment, I certainly want to move over to our deputy county manager and ask for any follow-up presentations or comments that he may have. But thank you, Anthony, for the Med Assist. Now that was a good one for me, and I really appreciate that information in the presentation by Ms. Stansfield. And certainly the pre-K program is, as you can see.
Well, I anticipated some of your questions, and also one, thank you all for your investment in the 10-year study. That we are tracking these students, and I think our comprehensive review of this program will definitely prove to be beneficial to continued investment. So it's just the timing of getting you a report on that 10-year study is something that I'm going to talk with Tim about and make sure that we come back to the board with an update on that information, as well as have further conversation with Tim and Kim and CMS on some of the questions and concerns that you have. What was brought up at the budget retreat was really focused on a manual pool by CMS more so than having those unique CMS identifiers. And that was some of the issues that was discussed. But definitely, I understand that this, the manager will be coming before you with a budget, and you all will ask questions of her and CMS. So I want to make sure that you have answers before then. So we'll definitely work on that. And also want to thank Ms. Stansfield and the Med Assist team. Definitely, as we think about your priorities and continue to invest in your priorities in all of the areas as it relates to the social determinants, the free pharmacy benefit is huge for us and our entire community. So thank you, Ms. Stanfield. Tonight, you will hear a presentation from Ms. Henderson on transportation, and I'm excited for you all to receive that presentation as we have, we're shifting away from COVID era funding to our general fund, and some of the things that we've done in the past, we're not able to continue to do, such as the single trips for individuals that were focused on social distancing more so than just the need for some of the trips. So I look forward to you all receiving that. And also, I know there was some miscommunication that was out there. I received an email from Commissioner Powell earlier today, and that was miscommunication. If you could just address that real quick before we close.
Certainly. Thank you, DCM Trotman. So commissioners, there was a communication that trips, adult daycare trips, we provide trips to adult daycares for our seniors and those who are disabled, would be reduced or eliminated, and that is an error. So that is not accurate. They are not among the category of trips that will be evaluated that would be sunset because the COVID funding has run out. And so we will be sure to clarify that during our presentation today. There was about a 3 or 4 day period where staff was communicating that those trips would be reduced, and that made its way out into the community. And once it came to the attention of leadership, we promptly corrected that, called everyone back, restored all their trip eligibility, and we will move forward accordingly after tonight.
So no adult daycare transportation will be impacted.
That's
okay.
That's correct. Yes.
All right. It sounds like everybody's happy. Thank you. But thank you so much. Anthony and your whole team. You know, I really learned something really important today, and that's what these things are about. Not only for me to learn, but also for the public and other commissioners. So, thank you all. And is there a motion for adjournment for this committee?
Before I make a motion, I just want to thank you, Chairman Griffin, for caring so much. You carry it with you everywhere you go and in everything you do, and it means a lot to us. Thank you.
It's a good team. I'll put it that way. All of us. I think one of the blessings that I have, sometimes I fuss a lot, but the passion that we all bring to the table is important. We just have to connect that passion in such a way that it has a bigger impact. But I love you all.
We love you.
All right.
Thank you.
Motion?
Move to adjourn.
Second?
Second.
All right. Any discussion? Hearing none. All those in favor say aye.
Okay.
Pose the same sign. Go to lunch. Enjoy yourself. Meeting's adjourned. Thank you so much.